Good morning, and thank you all for coming here today to a truly exciting program that we have in store for you. It's our chance to talk to you about AI transforming health and improving impacts for human health. So we'll start off today with having the honor of having Dr. Tomás Díaz de la Rubia give some opening remarks. He is the Senior Vice President for Research and Partnerships here at U of A, leading a $1 billion research enterprise that we have in advancing our strategic partnerships and connecting discovery to impact that he will tell you much more about. Tomás previously held positions in senior leadership at Lawrence Livermore National Lab, Purdue University, and the University of Oklahoma, and currently serves on the Defense Science Board advising the U.S. Department of Defense. He is a fellow of the American Physical Society and the American Association for the Advancement of Science, and a member of the National Academy of Inventors. He is recognized as one of the world's most cited scientists. Please welcome Tomás.
Thank you. Okay, so how do you like this? You know, you got a computer scientist and a physicist talking to a bunch of health professionals. I love it, right? Convergence, right? We're trying to bring things together. Thank you for the introduction, David, and thank you all for being here this morning. What a great turnout! I mean, this is exciting, very, very exciting. I wanna tell you, going back, who's that good-looking guy? Look at that. Good picture, David. I want to tell you, going back to this theme of convergence and, computer science and physics, I am a physicist by training, right? And I started my career as an undergraduate doing research in the laboratory, okay? In an accelerator, particle accelerator, ion beams, this and that. And as I went into graduate school, the work at the lab started to get harder and harder. And one day, my thesis advisor, this was back at Argonne National Laboratory in Chicago, looks at me and he says, "Would you like to do computer simulation instead?" He said, "This thing in the lab isn't going very well. I'm not good at tinkering with stuff." So I got into computer modeling, right? I got into atomistic, both classical and quantum-based atomistic modeling of materials and physics. And then one day, fast forward 10, 15 years or something, I was doing big simulations on the biggest supercomputers on the planet, using, again, what's called molecular dynamics and quantum-based molecular dynamics and Monte Carlo and things like that. Anyway, so one day a friend of mine at IBM in Almaden, who also a physicist, calls me up and says, "Hey, Tomás, what do you think about us trying to do some molecular dynamics to see if we can fold a protein?" I said, "Farid, I know nothing about proteins, but, why not? Let's try." So here we go, two cowboys, with a big supercomputer thinking we're going to fold a protein from first principles and give you the structure of the protein, right, on the computer from first principles, predictive. Well, fast forward another year and a half, zero, nothing, impossible. There's not enough silicon on the planet to fold a protein on the computer, okay? Just cannot be done. It takes too long, it's too complex. If you're gonna do it atomistically, from fundamental first principles. So fast forward then another, 15 years or something, and what happens? The Nobel Prize gets given to two Google scientists for using AI, AlphaFold, to predict the structure of proteins, right? That's why we're here. Because the ability of AI today and in the future to advance science across the board, obviously in health, but across the board, is just blossoming right now. And I think we're just at the very beginning of truly a transformation and a revolution. So I'm really excited to have you all here today, because I think, when President Garimel and I started at the university almost a year and a half ago now, time flies, right? We talk about, what might be some initiatives that we could do to launch some new ideas into the university, bring people together, right? This idea of convergence, this idea of how do we bring folks from across the entire campus, build on our strengths, and do some new things, build on those, and create, momentum around those ideas that can lead to new discoveries, new science, new technologies, new engineering, new social systems that can have an impact on society. So we look at, I'm going to get out of the microphone. Can you all hear me? Yeah? Okay. So we look at, if you look at what's happening in the 21st century in the planet, it's a very complex place. Right? We got, on the one hand, there's climate change, the continuous unabated. Greenhouse gas emissions continue, in fact, they're growing. Doesn't matter what any website, with the job role thing at the end. Oh, thank you. Yes, sir. What any website with .gov at the end says, climate change is real and it's accelerating, right? We have tremendous geopolitical stresses. Boy, this is going to be loud. Okay. If it's too loud, I'll take it off, okay? We have tremendous geopolitical stresses all around the planet, right? You wake up in the morning, what's happening? The Middle East, Ukraine, the Indo-Pacific. There was an article yesterday in the New York Times. If you didn't see it, really, really interesting article about Taiwan, semiconductors, and global conflict. And it brought together this fact that Silicon Valley has been asleep at the wheel. We're not able to manufacture leading-edge semiconductors at the 2 nanometer or beyond node. And we're completely dependent on Taiwan. I just came back with the president from a week in Taiwan, and it's amazing what they're doing there. Thankfully, they're bringing their semiconductor manufacturing to the US, but there's tremendous stresses all around the world. At the same time, we just came out of a massive pandemic that killed millions of people. So lots of stresses. So how do we think about a university doing research that has the potential to impact society? How do we bring our strengths, our capabilities to advance knowledge that leads to new solutions for the benefit of the planet? So we looked at that and we said, okay, let's start some new ideas, some new directions. And we did the Big Idea Challenge, right? Some of you, right, put in proposals. We had 72 proposals. We said, okay, here are the stresses that we want to tackle. Here are the grand challenges that we want to focus on. Bring us your ideas, big ideas that have the potential to truly be transformative and to build on our strengths and bring funding to the university, bring more resources to execute on this. So there were 72 proposals. Some of you participated in the review. We funded 6. It was a pretty tough competition, right? And these big ideas are just blossoming right now. For example, one of them was about building data centers in space. How cool is that, right? We talk about data centers, energy, water, right? It's a big, big social problem. Energy demand is going through the roof. Greenhouse gas emissions are going to go unabated through the roof because the only way we're going to power all those data centers is with natural gas for the most part. How do you solve the problem? Put them in space, right? There's a lot of interest in that. We're working on that at the university. It's just one example. But we also then launched, 3 or 4 new initiatives that we presented to the Board of Regents. The first week I was here, the president and I met with the Board of Regents, with Ebert, and we proposed to them 3 ideas. I talk about geopolitical stresses. You all know that as a university, we have huge capabilities in space, right? We're number 1, number 2 in the world in astronomy and astrophysics. We have an incredible history with NASA. I was just with the NASA administrator last week in Washington, D.C. He's all in on university-based science, funding that at NASA. It's a whole transformation of how they were thinking about a year ago. We're getting great support from NASA on all our missions. We've been doing that for decades, for 7, 8 decades, right? We've been at the top in the world of astronomy, cosmology, astrophysics, space, and we have this challenge in global national security. And where the challenge is most important right now is happening in space. Space is no longer a benign place where we just put communication satellites. Space is a domain of warfare. Space is contested today. Our adversaries are up there trying to gain space superiority so that they can control the entire economy of the planet. Not just on Earth, but on the moon and in other places. So space and national security became one of our major initiatives because we think we have capability and assets to contribute to that very important mission and to help our warfighters, to help our defense enterprise protect our liberties and our freedoms against adversaries. So that's one. Then we look at the question of energy, right? And we said, okay, so, there are a lot of energy questions out there, but what's the ultimate solution when it comes to providing sustainable, clean, dispatchable, baseload power for the planet for centuries to come? It's fusion energy. It's the energy that powers the stars, right? It's the ability to fuse two hydrogen isotopes together at extremely high pressures and temperatures in a controlled way, and to do that in a way that becomes commercial. That's the challenge. The science of fusion, the breakthrough happened 3 years ago at Lawrence Livermore Lab, where I was for 24 years. We showed that using lasers, you can compress a hydrogen capsule to the conditions of pressure and temperature that lead to fusion ignition, plasma burn, and energy gain. More energy out of the fusion reactions than laser energy winning. That was a major scientific breakthrough. Now, how do you turn that into commercial power plant? That's a big technical challenge. It's a big technology challenge. It's very difficult. But I'll tell you what, it's a challenge that working with the private sector and working with the federal government in private-public partnerships, this university can be up to that very, very difficult task and may be one of the leaders globally in bringing fusion to the market in the next decade or two. Okay? Very difficult challenge, no guarantee of winning, but that's a challenge worthy of a university like the University of Arizona. So we launched straight out into this question of fusion and how do you bring fusion commercialization, how you bring fusion to the global markets. I want Arizona to be the place where the fusion industry grows, where the fusion industry is born and where the fusion industry grows and becomes the leading element of the future energy solution for the planet. And then we talk about AI, right? Who doesn't? AI is everywhere. We talk about AI all the time. What are we going to do with AI? And then we said, okay, now here's, I talk about astronomy and astrophysics and how we have strengths in there that are very unique. We have two colleges of medicine. We have a college of pharmacy. We have nursing, we have public health, right? We're a powerhouse when it comes to health science. We said, well, let's couple AI with health. Because the huge potential, I told you the story about protein folding. Of course, that's just the start. That's just the beginning of it. But the huge potential of AI across the board, informatics and data, and the ability to use data to improve everything from discovery of new therapeutics to clinical trial planning to cancer treatments to doing cancer, digital twins. We're working with Dr. Theodorescu on across the board, right? Healthcare systems, healthcare management, healthcare operations. We're just starting to see that. And this university, with the strengths and capabilities that we have, we believe can be a leading voice in bringing, responsible AI, and David is going to talk to you about that, responsible AI, ethical AI, into the healthcare system to improve health outcomes, to help rural communities, telemedicine, bringing AI, machine learning, telemedicine together in rural communities, for example, to improve health outcomes in those communities. So that's why we're here today. Okay. The Board of Regents was extremely generous. They gave us $20 million. You all saw that. We announced that to start with those initiatives. We're also now focusing on mining and critical minerals and, of course, desert agriculture and water, other areas that we're very strong at in the university. But the Board of Regents gave us resources to get us started. And that's when we brought David in as the Chief AI Officer. There are very many universities. Duke University has a Chief AI Officer. There are some around, more and more. But I think this idea of having a person on campus who is helping us think about and understand how we're going to responsibly use AI across the entire spectrum, right? From education to research to operations, helping coordinate all of this. That's what David is doing, in addition to helping us launch this AI and health initiative. So anyway, that's where we're at. We're really, really excited about what's happening at the university, the momentum that we're gaining across all these areas, the response that we're getting from our alums, from our donors, from the federal government, from the private sector is tremendous. And what you're doing here today is just the start, I believe, for something that is going to be really, really exciting. Enormous amounts of potential for intellectual property, for startup companies. Doug Hochstadt is here also. You can go grab him, say, I have, we have one of the best technology commercialization engines in the country at this university, and startups, Doug knows this. We've done about 15 startup companies a year on average over the last 10, 12 years. I told him we got to double that, right? We're going to do 30. So anyway, look, all of this comes together through convergence, and again, I think the potential for what we're doing is tremendous. Delighted that you're all here, and looking forward to hearing what the outcome of the conversations today is. So thank you so much for being here. Hey, do I introduce you? No, you're good.
Yes.
Okay.
Yep.
Okay. And Patty's going to be here at lunch, right?
Yes.
Yeah. All right. And the Brothers will be here at lunch, so that's good.
No, is this yours?
Yeah. Yes.
Okay. Okay.
So this is your first one.
Okay. Well, again, let me reiterate, we're so thankful you all took your time today. You've got busy jobs, you're doing important work, and the fact that we've gotten so many people with so many different backgrounds together to talk about this topic and to help us create the best path forward is really what this is all about. You're going to, I'm humbled by the people you'll be hearing from today with amazing work that they've been doing. And I'm just going to give you a bit of an overview of what we've been doing here. Now, as Tomás mentioned, and I see it constantly, AI is changing everything we do. It's changing how we live. It also is changing what we're able to do to improve health outcomes. We're able to detect diseases earlier than ever before with AI-assisted imaging, biotechnology, and with sensor innovations that allow us to do things that we haven't done before. I mean, here's an example of a smart bandage that has been developed here at the university by Jeff Gertner. It's incredible that you can now find the first sign of infection when someone has an issue where they're covering the bandage after surgery and get them treated before it becomes a critical thing. This is just one example. We have people detecting Alzheimer's earlier and earlier so that interventions and plans can be taken. These are the type of things that we're doing. We're unlocking, and to me, what I see coming in the future is really the ability that you wake up in the morning, the sensors that you have, your phone that's been listening to the ambient sounds and the ambient sensing you have going on has found that there's a change in a pattern. It sent the information to your physician, and they've started seeing what's the anomaly in you and has decided, you get a call that you need to come in and discuss this. And they're able to detect things even before you feel it. Maybe you weren't quite feeling right, but you didn't think it was you thought, it was not enough sleep. And these are the type of things, and we've got a sleep expert here today too, but these are the type of things that we're talking about being able to go to so that you can detect the conditions at their earliest start so that we can then come up with novel immunotherapies to be able to treat things like we haven't been doing before. We have, personalized, genetically targeted treatments that are now available. We're able to deliver these in ways that we weren't able to before. This is not, out to everyone in the US yet, not to every, Arizonan and to everyone. And that's what we're working on, is to make sure that everyone has access to these innovations and we're able to do this effectively and improve the health outcomes for our entire population. And that's why we are really building the leadership with the work going on across the university to transform how we innovate the discoveries, accelerate how we go from lab to clinical practice and improve health outcomes for our entire population. So our mission is to be a national leader in doing this. And we've got the core talent, but we need partnerships. We need people to be committed to this and the inspiration from all the great ideas that you have. And so that's why we're having you here today. And, this is not something that's new that the university is doing. When I did a quick search through our funded database, there are already $32 million in funded federal grants that are using AI and machine learning to transform the way we study and understand health. And we really have been working to make sure that we're a national hub for responsible AI, going beyond ethical AI to make sure we understand the social impact of what we do, the sustainability impact, the legal and regulatory impact, that we're considering all of those things. So we're being judicious and trying to be effective and efficient in the use of what we're doing with this. And we're very fortunate that we had, as Tomás mentioned, the funding from the Arizona Board of Regents to jumpstart this. With that, we created the AI Health Initiative. We have a strategic forecast deciding where we want to focus and where we can be worldwide leaders. And we're now starting to move into the implementation portion of that. And one of the things that we've done is created the AI Health Innovation Nexus. We're not creating a new center on campus. We've got amazing health centers and institutes across campus and expertise. We are building the nexus to bring all those people together across all our campuses to enable us to innovate and come up with a whole solution for this. And, we started a health innovation pilot and program where we have internal funding that we're giving out, and we'll probably do another round of this. But in the first round, we got 60 submissions. We're finalizing. I was hoping we would be able to announce the ones that were selected for funding here today, but if you're used to working with academics who are very busy and have great expertise, everyone doesn't necessarily get their reviews in on time. And so they will be coming out shortly. We're hoping that easily by the first week of March, we'll be able to announce that. And the quality and ideas that people have are just so amazing. And, we're really trying to see how can we improve the entire health ecosystem in doing this. So we really are, the areas we're focusing on is accelerating discovery and translation, enabling more precise, personalized medicine and treatment, reshaping care to be real-time and accessible for all. You'll hear from people who are doing amazing work in telehealth and rural health and innovations in smart sensors today. These are the things we want to do. I always say that, those of us here at the university are right next to a university research hospital, and we have some of the top experts in the country that are available when we have a problem. A large percentage of our population don't have that, and they may have long drives to get care. They may not have high bandwidth right now to do telemedicine and telehealth. They might not be able to get advanced sensors into their current environment. But we need to change this, and we need to innovate and make sure that we're able to move forward. So we're really wanting to make sure that you get the same quality of care if you're in a small town or if you're right here next to a university medical center, right? We want to make sure that everyone has that available. And we're doing this by really advancing our strategic partnerships. We have strong partnerships with Banner Health, Envita, TMC, and health systems across the state. We are growing that, and we're really making sure that we're reaching beyond and creating nationwide and international networks to improve what we're doing. So that's the approach that we've been taking. That's some of the initial work we've done. We launched the strategic forecast in August, September timeframe. That was completed in November, and now you're starting to see some of the ways that we're moving forward. So we invite you to become active participants. Give us your ideas, be willing to work with us, and help us grow this. Our view is the money that we're giving from ABOR is the seed corn to create an incredible crop that will allow us to create and feed an innovation ecosystem to really transform human lives. And so as we go through today and you hear all of these ideas and opinions, hopefully it will start give you a lot of insight, but start a lot of discussions in what you're doing, create ideas, and give you opportunities. We want you to engage and be active participants. We're trying to make it so that there's some predefined questions for our panels that we think will get a lot of lively discussion, but we want you to participate. Make sure you ask your questions, challenge each other, and it really is, I'm a strong believer. I've been doing convergent research for the past 15 years and creating solutions. interactive solutions that help people solve a problem, make new discoveries, make streets safer, optimize worldwide shipping routes, and increase the ability of doctors to provide care. So, to me, that doesn't just take a computer scientist. You need domain scientists, you need economists, you need sociologists. Convergence is key to what we're doing. So we really ask you to bring all of these aspects, your concerns and your ideas together to help us lead the future of better health outcomes. So hopefully that set the stage and gave you a warm up. It's always hard to follow Tomás. He's an incredible speaker, and I always prefer to go before him, but I've dealt with that a long time. And basically, but this is just the beginning of the day. What's coming up is super excited. I'm very amazed by the people that we have that have agreed to present today. We will be doing a series of workshops and presentations, a speaker series. We'll be having another Health Innovation Symposium in the fall that will really focus on some issues and where we're going. And with that, I'll turn it over so that we can get to our first keynote speaker, who unfortunately talking about all of the issues and how everything needs multiple expertise to come together. He was not able to be here because of a problem with his plane, and with the weather occurring on the East Coast and the unavailability of other flights, he could show up at 4 p.m. today with rerouting. So we will have him via Zoom, but it'll be just as exciting. So thank you very much.
We're going to let him in.
Huh?
He's in the waiting room,
Yep.
so we're going to get him in.
Okay.
Is that him? Let's see. He should be in. See if he could.
There was somebody that met. Can you hear us?
So while we're dealing with the Zoom, I will get started.
Joseph, can you make sure that Payne's on? Philip's on. Just so you can. Philip, can you hear us?
I sure can. Can you hear me?
Perfect.
Great. And we see you. Perfect. Okay. So it's my great pleasure to introduce our plenary speaker, Dr. Philip Payne. Now, how do we get him from the back screen to the front screen? He's on. Somebody waved, they're doing the magic. Okay. Okay, so if you want to see his slides, look forward. If you want to see his face, turn around. I told you it was a high-tech room, Philip.
I like it already.
When we talked about having a conference on AI in health, and David asked me to help identify some speakers, Philip was the first person who came to mind. And that's not just because we both grew up in San Diego, or the fact that he was my graduate student. And I brought this to prove it. If you have any doubts, you can borrow it and read it if you're interested. But Philip is a case of the student vastly exceeding the teacher. And that was obvious to me from the very beginning, but really when he went from assistant professor to chair of informatics at The Ohio State University. From there, he got recruited to Washington University in St. Louis as the founding director of the Institute for Informatics, Data Science, and Biostatistics. Now, he is the Chief Health AI Officer of BJC Health and Washington University Medicine. He's Vice Chancellor for Biomedical Informatics and Data Science. He's a Janet and Bernard Becker Professor in General Internal Medicine and Computer Science and Engineering. He's also the president of the American Medical Informatics Association, the leading professional organization in this field. He's been elected a fellow of the American Medical Informatics Association, the American College of Medical Informatics, the American Institute for Medical and Biomedical Engineering, and the International Academy for Health Sciences Informatics. Yeah, I don't come close. He's got over 300 publications across various domains in AI and digital health. He's founded multiple companies in the space. He advises government bodies, companies, and venture capital firms. And he made Washington University a leader in the use of synthetic data to build collaborations between industry and academic medicine. So now that I've totally intimidated myself and hopefully you, I will hand it over to Philip.
Great. Thank you, Justin. That was a thoroughly embarrassing introduction. And as I remind everyone, you should take credit for everything that I've done so far, because I would not be here if not for the training that I received at Columbia and really in your lab. So I do deeply appreciate the invitation. I'm also very sorry that I am not there in person. If anyone knows the story behind this, the travel sort of gods were not in my favor yesterday, which involved a 6-hour delay. So I was unable to get there, but I promise I will come and visit soon. I'm looking forward to meeting everybody as sort of potential collaboration comes together. So with that, I really want to get to sort of the topic at hand, which I hope will sort of, help set the stage for a lot of what's going to happen at your meeting today. And I want to talk about the role of artificial intelligence and digital transformation together in driving an evolution in health and healthcare. And I am going to use a few examples from our own work here at both Washington University Medicine and BJC Health, but I will hopefully draw some connections that I think are familiar with the environment in which many of you operate. So it looks like someone else is driving for me, so maybe we could go to the next slide.
I'm driving, Philip, so just let me know when to advance.
Yeah. Next slide, please. So I rarely read quotes in, talks, and I'm not going to do that with this quote, but I just want to set the stage by saying I think we can all acknowledge that the current explosion of interest in artificial intelligence is both very exciting and presents a lot of challenges and opportunities for all of us. But I think those are no more important than in healthcare. And that is because we are a field that is intrinsically complex. We have lagged in digital transformation, and I'll talk more about that in a moment. And that has had some impact on our ability to scale cost-effective, high-quality, and safe healthcare. And right now, a lot of the innovations that we've thought of as being laboratory-based have suddenly become practical to implement at scale in healthcare delivery systems. And I think that's at both an interesting time, but a time in which a lot of care and attention to how we responsibly deploy these technologies is going to be essential. So if we go to the next slide. Part of this, and I think I've already alluded to this, is just this sort of step change in technologies available to us. And I'll sort of use as an exemplar of that the book that I included a screenshot of the cover of here, ChatGPT MD. To the best of my knowledge, this is the first book where a large language model is one of the co-authors. I'm not sure if we agree or disagree with that idea, but it just shows how quickly the field is changing. AI has gone from something that highly skilled computer scientists might use in a laboratory to something that can be used as more of a commodity and a partner to human beings in writing a book about the future of medicine. And that has literally happened in a period of just around 5 to 10 years, if you really think about sort of recent transformer-based technologies and large language models. And we are quickly moving towards an environment in which adaptive systems that combine multiple types of artificial intelligence alongside humans are going to become the norm and not the exception. And so that begs a lot of the questions that I want to talk about today. So next slide, please. Now, I'm going to use a few terms throughout the talk, and I just wanted to sort of lay some foundational definitions here. I think this group obviously very familiar with artificial intelligence and the multiple subtypes of artificial intelligence that exist. But I'm also going to talk about digital transformation, which is really a broader view of how we bring modern digital technologies, so that's computing, data, and communications capabilities, to bear on all aspects of a business, in our case, health and healthcare, to change how it fundamentally operates. And the key here is transformation, because this is not about taking technology and bolting it on to existing workflows that may be suboptimal, but rather fundamentally re-engineering how people, processes, and technologies work together. And I would point out that that is also the foundational basis of the field of informatics as a scientific discipline, the study of that intersectional space of people, processes, and technology. I did include also this heat map, which I love, which is that AI is not a monolith in this context, but rather a constellation of technologies that have variable degrees of sophistication, maturity, and ability to solve the types of use cases that we often encounter that, again, combine computing, data, and communications needs. So if we go to the next slide. One of the things I'm often asked, and I want to say this at the outset, is, do I think that AI is going to replace humans in some aspect of how we either pursue research or teaching and learning or delivery of care? And I will say, I do not believe that is the future that we are building. I think rather, building on this sort of fundamental theorem for biomedical informatics that my good friend and colleague Chuck Friedman proposed in 2009, it is the combination of computers and humans working together that are superior to either working alone. And there's a lot of reasons for this, most notably because humans are very good at pattern recognition, and in ways that even with the most advanced AI, computers cannot replicate. In contrast, computers are very good at dealing with data on a scale and scope and at a speed that we cannot. And therefore, in a complex environment like healthcare, where we have an incredible amount of data, one might say a tsunami of data, bringing those two threads together is intrinsically superior than either alone. I also think it's important to recognize when we talk about AI, as intelligent as these tools appear, some people might call, for example, new large language models nothing more than a stochastic parrot. It's a little bit of a pejorative term, but fundamentally, these technologies appear intelligent because of their speed and scope, not because of innate intelligence. And I think we need to recognize that as we navigate this new normal where AI becomes a partner to humans in the healthcare setting. So if we go to the next slide. There are lots of ways that partnership generates benefit. And I'm not going to read all of them here, but I think, again, it goes to the fundamental problem that we face, which is that most modern questions that we encounter, whether it's in the lab or in the clinic or in the population health setting, involve not just a few dozen pieces of information, but often thousands, if not 10,000s or hundreds of thousands of individual elements of information. And we as humans are not good at dealing with information on that scope. But if we have AI and humans working together, we start sort of opening up the door to more rapid data processing and analytics, the ability to find patterns that maybe are hard to surface without some of the sorting and filtering that AI provides us. And certainly it helps us to think more critically around how we reduce errors and increase the efficiency of care delivery by being very smart about how we allocate people, resources, and processes to care delivery. And so it can be argued that there are a lot of potential benefits, some already realized, some not, that we see with AI in a digitally transformed healthcare delivery system. So if we go to the next slide. And then if we can just click to cause the animation to come up. So, doing this is not easy because we fundamentally need to deal with sort of some really sort of critical needs that healthcare delivery systems traditionally have not excelled at. First, we don't really have an AI-ready workforce in our healthcare systems. By and large, these technologies are still new. They're not part of how we train future clinicians, with a few notable exceptions. And we really have to start getting people ready to think critically about where, when, and how to use them. Second of all, especially for our clinicians, the people making decisions, we need to understand how they influence sort of the cognitive processes that lead to diagnostic or therapeutic decision making. And the technologies are not benign. They can introduce biases, they can create ethical challenges, not to mention they can change sort of fundamental performance in a dynamic system over time, and we need to recognize that. And then lastly, and I think this is the most exciting sort of observation as we sort of look forward to sort of a more digitally transformed healthcare delivery system, the embedding of continuous learning into the delivery system will become essential because these are not static tools. They change over time with use. They in turn change the system in which we operate. Again, those people, processes, and technologies. And so now, research or sort of tracking and evaluation is not something that happens in the lab. It's something that has to happen everywhere in the delivery system if we're going to optimize these technologies. So if we go to the next slide. Now, this goes to the idea of digital transformation, and I love this quote from Bob Wachter. And actually, if you've had a chance to see his new book, I think he really expands on this even further. But transforming healthcare through digital technologies is hard because it is both an enormously complex business, and then simultaneously, it's the most human endeavor that we engage in, right? The stakes of the decisions that we make could not be higher in health and healthcare. But if we can balance between those sort of two extremes, and we think about how we re-engineer workflows to take maximum advantage of these digital technologies like AI, we can reimagine how we deliver care. And I'm going to give you a few examples in this talk. We can start creating greater integration. I would doubt that anyone in this room has ever experienced a healthcare system that felt integrated and coordinated, because they are by and large not. It can augment decision-making so we can avoid potentially deleterious outcomes that could be prevented through the application of the best possible scientific evidence in the right time, place, and format. And we can also start thinking about how to increase value so that costs decline, but quality and safety improve. And this is where we think more critically about how we deliver care and why. And so really, digital transformation is sort of a broad umbrella or a broad tent that would allow us to think about how do we re-engineer the entire environment to take advantage of these modern technologies at our fingertips. So next slide, please. Now, something that I think is very important is that having an ambition to be digitally transformed is not the same as actual digital transformation. And I actually love this infographic from McKinsey that sort of describes the 6 pillars that are required for digital transformation. And what you'll see is very little of it is actually about the technology. It's much more about, do we have a strategy whereby we sort of set our North Star to take advantage of these digital capabilities? Do we have the right talent or workforce? Do we understand our operating model so that we know where, when, and how to inject these technologies? Importantly, if you look at Pillar 5, do we have the right data to be able to take advantage of these technologies? And many people look at modern AI and they think it's an easy button to get past some of the data challenges that we have in healthcare. It is not. If anything, our sources of data and their rigor and quality and completeness have never been more important. And then how do we adopt and scale technologies? Just making something work in a pilot is not transformational. Making a technology work at scale across a clinical service line or a hospital or a health system is where transformation happens. This is much more about people and strategy and incentives than it is about technology. And I want to emphasize that point because many people say they are engaging in digital transformation, when in fact what they're really doing is evaluating technology. And those things are not synonyms for each other. And I'm going to keep coming back to this theme throughout the rest of the talk. So if we go to the next slide. So now I want to transition with that sort of preamble and talk a little bit about why now is the right time to think about the use of AI and digital transformation principles, and how that could help us to improve access, quality, and outcomes of care. And I'm going to use the story from here in Missouri to amplify that point. We go to the next slide. So first and foremost, if you think about the healthcare environment in Missouri, I often describe it as a tale of two states. And that is because there is a massive differential in healthcare access, as well as the quality and affordability of that care between our major urban centers, right, in St. Louis and Kansas City. And those are sort of the two big sort of urbanized areas you see on the edges of the state. There's often a joke in Missouri that the two largest cities both look like they're trying to escape the state because they're both on the rivers that make up our borders. And then a few smaller dense areas of healthcare access around areas such as Columbia, Missouri, where our land-grant university is located, and in the southwest corner around Springfield. And the rest of the state is actually positioned as a mostly healthcare desert. That is because we have incredible geographic dispersion, as is alluded to sort of my comments, and we've lost a lot of hospitals in the rural parts of our state, largely because of financial challenges, but also consolidation in the healthcare system. We also have a huge workforce shortage, and I'm going to give an example of that in a moment, but we have many hospitals that simply cannot staff, or ambulatory clinics that cannot staff because there's not trained clinical workforce to meet the needs of those communities. We have huge infrastructure gaps. So for most of our rural providers, even basic broadband connectivity is a problem. So bringing virtual care into those environments remains a major challenge. And then there are socioeconomic barriers, including how do we transport patients across the state when they need specialized care? We have incredible rates of chronic disease as well as diseases like cancer in some parts of the state, particularly what we call the boot heel, sort of the southeast corner of the state, where we have sky-high cancer incidence, especially in colorectal and breast cancer. And yet we've never been able to identify a clear epidemiologic driver of that cancer incidence, and access to cancer care in that part of the state remains very challenging. So when you take this as a whole, you have individuals living in urban centers that have access to world-class healthcare and have superior outcomes, but perhaps with high costs associated with it. And then you have a large and sort of geographically dispersed rural healthcare environment that is mostly underserved. So if we go to the next slide. Now, this leads to a lot of differentiation in terms of health outcomes, cost, and access. The state has a lower life expectancy than the national average. Most of our healthcare system, with a few exceptions, like the one that I am fortunate to work for, have below average system performance. And the only places where we see sort of above average performance and what I would describe as adequate levels of quality and outcomes are in rural regions. And even there, it's highly heterogeneous across medically underserved and well-served dimensions of those urban areas. We have very high avoidable mortality rates in the state, and one could argue that is because of inadequate access to emergency care, as well as maternal fetal medicine and chronic disease management. We have a huge affordability burden, and I'll get to that in a moment. And then I would say, simultaneously, we're not inexpensive. If you look at sort of personal healthcare spending, both in terms of insurance products and other sources of healthcare spending, we are at above national averages. So that means basically our patients have an affordability crisis around access to healthcare, while our outcomes are inferior. So I don't think anyone would argue that that is sort of a desirable state of affairs for any geographic region, and it's certainly something that we focus on in the state. So if we go to the next slide. Now, we did expand Medicaid in July of 2021, and I'll spare you the lengthy history behind that, but this actually involved passing a constitutional amendment through a popular referendum, and that effort was actually led by several of the large healthcare delivery systems in the state, including Washington Medicine and BJC. And you can see here sort of how that has sort of manifested, and these are data from 2023 that sort of show sort of relative rates of uninsured versus insured patients 2 years after the sort of launch of Medicaid expansion in the state, and sort of the shifting demographics of how people are getting healthcare in the state. And if we get the next part of the animation up, one of the other things that you'll see is, importantly, the volume of uninsured patients in the state have declined. Now, the one thing I will say about this is in the current dynamic policy environment, we are highly reliant on federal subsidies, and we have a constitutional amendment that requires this level of access. This would create an unsustainable gap in the state budget if we were to lose federal funding for Medicaid expansion. So Medicaid expansion, while passed and while it has positive outcomes, is not necessarily something that we would consider to be durable in the state so far. So if we go to the next slide. I will point out that there are other trends that are not unique to us, including a strong driver from especially payers to move to outpatient and community-based care, although access is very problematic. We have a lot of consolidation happening, including consolidation led by my own health system, and I'll talk more about that. We have workforce shortages, which are national in scale. We are looking at an environment that has more value-based and risk-based payment models, which healthcare delivery systems are not necessarily familiar with implementing and succeeding with, and a push, including from our state regulatory bodies, to accelerate digital health adoption despite some of the headwinds. And so these are things that I think are not uncommon, but are sort of a backstory for much of what is happening in our state and many other states with similar demographic and geographic challenges. So we go to the next slide. And just trigger the animation for me. So this is where our health system, which is the combination of both Washington Medicine and BJC Health, comes into play. So we are a relatively large system with 28 hospitals. We cover 3 states, Missouri, Illinois, and Kansas, with the bulk of our facilities in the state of Missouri. And we see about 6 million patients a year and have over 44,000 employees. It actually makes us one of the largest employers in the state of Missouri and one of the 2 largest delivery systems in the state. We also have an incredible volume of ambulatory care. And then on top of that, WashU Medicine, which is the specialty care group that is based in our School of Medicine and is exclusively integrated with BJC, is an additional sort of enterprise with about 2.6 million patient visits per year. So when you put this together, this is a $15 billion business with 28 hospitals covering 3 states and is squarely in the middle of that challenging environment that I talked about. However, one of the things you would see if you sort of drill down is we are heavily anchored in the major metropolitan areas, and we have sort of a light footprint in the rural areas that I talked about. And I'm going to get into how we are changing that and the role of AI and digital transformation in making that change possible. So if we go to the next slide. So what are we doing? How are we tackling some of these problems? And these should be familiar strategies, but I just want to share a few examples. So we have launched what we consider to be a comprehensive virtual care platform, which means any patient receiving care from us can access virtual care services 24 hours a day through our patient portal and mobile devices. And we provide on-demand services, everything from urgent care through a virtual care window to more conventional ambulatory visits where appropriate to follow up to hospitalizations. We have tele-emergency and tele-specialty programs, including access to our emergency medicine physicians on demand for individuals that cannot physically get to our emergency rooms, and also providing that expertise to community hospitals that are not part of our system. And this is really about how can we avoid unnecessary transfer activity, and I'll talk more about that. We also have remote patient monitoring programs, virtual post-acute care follow-up, and we have an integrated approach to both care management internally and externally with our partners. That's one example. We go to the next slide. We also have a very large critical and perioperative telemedicine program, so what we call the anesthesia control tower, which provides remote anesthesia monitoring across our entire clinical platform and with other healthcare delivery systems. We provide tele-ICU so that we can run ICUs remotely in our rural sites. We actually are able to monitor patients remotely through these technologies and use our sort of anesthesia control tower as a basis for providing expert care on demand. And we also align that with our training and technology innovation strategies to build new technologies. And you actually can see a screenshot, for example, of a unique human-computer interface that's been built for monitoring vital signs perioperatively in our anesthesia control tower. So if we go to the next slide. And then we have joint ventures. So recently, we actually launched a new joint pediatric facility with a rural health system in Springfield, Missouri. That's the 3rd largest city, again, in the southwest corner of the state. And we're actually going to provide a 100-bed pediatric hospital within a hospital there. And the bulk of specialty care that will be delivered in that hospital will be AI and digitally enabled. So we will be doing that through all of those tools I just talked about, not to mention that we'll be using connected care to allow people to have follow-up care at home. And this is really meant to prevent transfer activity across the state. Today in Springfield, the 3rd largest city in the state, there is no acute care pediatric facility. So if you have a critically ill child, the most likely outcome is they're going to end up on a helicopter going to either St. Louis or Kansas City. And this is to avoid that. That is not good for the patients or their families. But this is all about providing staffing, where we've had challenges staffing these facilities in a community-based system. And really the backbone of that is all the telemedicine, AI, decision support, and data analytics capabilities that I have been alluding to. So just a few examples of how we're trying to tackle those problems. So if we go next slide. And really, I would say this is a primary example of digital transformation. And I really love this sort of version of rewiring workflow that I'm alluding to here, where we are extending our specialty expertise beyond our urban centers. We're scaling across the state, especially in rural settings, using our digital infrastructure. We're using a multi-state network to allow for more load balancing and collaboration. We're doing remote management of chronic diseases, some of the most challenging issues that we see in our rural populations. And we're building a learning health system at the same time, because all of this data is being integrated and used by our researchers to come up with novel interventions to improve quality, safety, outcomes, and value. So if we go to the next slide. So with that, I do want to give sort of a realistic view of how hard it is to implement this type of digital transformation and take advantage of these technologies. So if we go to the next slide. So number one, I think, and I hope many would agree with me, that there is still a lot of work for us to do to be able to show that AI and other comparable digital technologies can reliably replicate expert human performance. There are certainly small examples, and they are growing where this is the case, and I'll talk about that more in a moment. But there's a lot of formative research to be done to show where, when, and how these capabilities can match or exceed our human experts. And that means there's a critical role for those of us in academic medicine to drive the types of pragmatic studies that will actually show these types of outcomes. It's also why, despite people being concerned that hyperscale tech companies are going to do all this work, the only people who can evaluate these technologies and understand if they have the desired impact are people that are involved in healthcare delivery. And that is our unique role. We need an evidence base for these technologies, the same as a novel diagnostic or therapeutic in a traditional view of sort of the innovation lifecycle would require. If we go to the next slide. However, I want to be clear that while I'm saying that we need a lot more evidence, there is reason to be optimistic, right? We have seen where these tools can improve quality, safety, outcomes, and value of care. So, for example, this is a study from our own group that's shown by using a sophisticated predictive model that looks at perioperative blood loss, we can reduce the cost of unnecessary type and screen orders and improve the utilization of blood products in the OR, a place that traditionally has been both very wasteful and deals with a very finite resource. And we were able to validate that with a 45 hospital retrospective study using the MPOG network, and now we're prospectively using that in our perioperative clinics today. So this is an example where decision support can improve quality, safety, and value of care, right? Less unnecessary laboratory ordering, better planning for blood loss in the OR, and we are reducing costs. So if we go to the next slide. I still think we have to really be very attentive to the issues around human-computer interaction, especially in high-stakes or sensitive clinical contexts where we're going to use these technologies. So, for example, we have a decision support tool deployed in our emergency rooms and other ambulatory settings that looks at patients with high chronic or acute disease burden and a very high mortality risk. And we ask the fundamental question, do they have an end-of-life care plan in place, or does a discussion around that need to happen? We can trigger an order to have our palliative care team consult, or we can divert patients, for example, from feudal ICU admissions to palliative care if that's the patient and their family's preference. This is a sensitive issue, right? We're talking about end-of-life care planning. But when you talk to the patients and providers, their general sense is this is a very positive outcome for the patients. But we had to spend literally 2 years figuring out how and where to deliver this type of information in a way that made sense with all of the ethical and moral challenges that go along with that type of decision. If we go to the next slide. There are a small number of cases, and I do want to acknowledge them, where AI is better than humans, especially in imaging-based disciplines, such as in radiology and pathology. And this is a place where we can offload less sort of human critical work to computational agents so that our human experts can focus on more essential pattern recognition tasks, more complex cases with higher cognitive burden. And one need not look much farther than, for example, the use of AI to identify incidental pulmonary emboli in all chest imaging, which we do in all of our hospitals today. Something that humans could do, but would take a lot of time. The computer can do very well, and then trigger what we call our PE response team to go see those patients in the hospital and reduce the mortality or complication risk associated with that. So there are opportunities here, although limited, and they do require substantial evidence, and in many cases, FDA regulation to be able to arrive at those sorts of outcomes. We'll go to the next slide. I also think it's important to recognize that in a patient-centered view of the world, which is essential, that there is a lot of positive feedback from our patient populations. Yes, we should be concerned about the ethics and sort of the regulatory dimensions of these technologies. But again, when there's appropriate transparency and disclosure of the use of AI, and the AI generates value to patients and providers alike, there's generally positive perception of that outcome. For example, there is a now well-known study that shows that when we use AI-driven tools to draft responses to patient messages in a portal, they're actually perceived as being more compassionate and timely than those that are written by humans. That's not an indictment of humans. It's just that the computer doesn't get tired of responding to requests for appointments or refills of prescriptions. And therefore, we can sort of set aside those higher friction tasks so that our providers can focus on those messages that are most important. We go to the next slide. I also think that our providers are seeing benefit, certainly in documentation burden reduction in our own system, and we have a publication pending on this. We now know that our providers, and we have just deployed our ambient scribe technology to all ambulatory providers in our system. But in an initial study of 500 individuals, we have shown a decrease between 2 to 3 hours of work per week in terms of documentation burden, an improvement in perceived quality of life, and no change in billable outcomes from those encounters. So that's real time savings for our providers, especially in some of the most challenging cases that they see. We go to the next slide. And then finally, we know that vended systems still have difficulty scaling. Again, the story of Epic's sepsis early warning system is sort of emblematic of that. And so despite what our vendors are telling us, there's still a reason to be very critical when we think about, can these general purpose technologies meet the needs of our systems? If we go to the next slide, to drive home that point, I just want to point out from a quote from my colleague Karandeep Singh, the Chief Health AI Officer at UC San Diego, that the reality is today, most of the systems we get from our vendors are not well studied and sort of subject to evidence generation, while those that we understand the best are rarely deployed operationally. And so we have to figure out how to close that gap, and that is an essential question for all of us as we move forward into this digital transformation era. And if we go to the next slide. And the last thing I'll just say is we have to have better capabilities for sharing implementation knowledge, like this meeting today. There's an interesting paper here by Chris Longhurst and colleagues that calls for centers of excellence around implementation science for AI in the clinical environment. But the key takeaway is we do not have the infrastructure today to make sure knowledge and best practices around the delivery of these capabilities is adequately shared, and especially when we think about under-resourced healthcare provider organizations that don't have the benefit of having academic data science, informatics, or AI groups to support these types of projects. So we go to the next slide. So I will say, just to sort of round out, I love this quote from Fei-Fei Li from Stanford, which is that the use of the term artificial intelligence is probably, if not certainly, a misnomer, because it is not artificial. We design it, we provide the constraint conditions and the training data and the criteria via which it's judged, and then we decide when and how to use it. So perhaps, much like the American Medical Association has argued for, we should really be thinking about this as augmented intelligence as opposed to artificial intelligence. And that goes back to one of my very earliest slides. And I think we need to be cognizant of that as we plan our digital transformation strategies. So if we go to the next slide. So I will round out by making an argument that's sort of a point counterpoint. So if we go to the next slide. One view of all of this, and I just want to say this is happening in a complex environment that is not orderly, that is not structured, that is constantly changing, and we need to acknowledge that, is that, and if we go to the next slide, we will end up actually contributing to more overload for our clinicians and patients. That we will use these technologies and will amplify bias, will disrupt focus, people will have a harder time using human judgment where it's appropriate, we may de-skill our providers, we may increase inequity in access, and we just may contribute to alert fatigue or other sort of comparable cognitive burden. If we're not thoughtful about the evidence base and addressing many of the questions I tried to raise today, this is a very real possibility and one that we have to be intentional in avoiding. So if we go to the next slide, the alternative and more positive view, which is certainly the view I have, is that this will actually help our providers and our patients arrive at more insights more quickly, and will sort of take some of the noise and friction out of the system that has defined it for the last several decades. We'll provide targeted insights. We'll actually be able to measure bias and understand how to impact decisions. We'll enhance our ability to focus on what matters. We'll provide decision support. We'll address the equity of access to care, and we'll provide personalized alerts. So if we go to the next slide. It's often said that a wealth of information creates a poverty of attention. And this goes back to this idea. Are we going to achieve more overload, or are we going to get to insight? And that's up to all of us in terms of how we approach these problems going forward. So if we go to the next slide. Really, at the end of the day, the question we're asking is, will the growth in AI capabilities keep up with the growth in data that we have in health and healthcare? There's certainly a scenario possible where data continues to grow at a rate that AI cannot keep up with, and we will lose the opportunity to make maximal use of that data. Or alternatively, if we take an accelerationist view of the world, AI will grow at a rate where we don't have enough data to train and evaluate it. Neither one of these are desirable outcomes. We all have to be intentional at sort of threading the needle and achieving what is described as scenario 2 here, which is that we grow AI capabilities in conjunction with the data that we need to train and evaluate it. And this is going to be very hard. There are forces at play to push for both high degrees of regulation or this accelerationist view of technology. And we will have to resist both of those to achieve this type of equipoise in the middle. So we go to the next slide. I'll just leave you with this story because I think it's sort of emblematic of what I was trying to get at. So this is an example of one of our patients at St. Louis Children's. He suffers from sickle cell disease, and fortunately, he's been cared for at St. Louis Children's Hospital for 10 years and has actually had incredible outcomes, right? And both he and his family have been able to live a relatively normal life despite the burden of this disease, which is both very hard to manage over time and can often be underdiagnosed or not diagnosed at all when it's necessary. So why am I sharing that story? So if we go to the next slide. This patient is fortunate because they are getting this care at St. Louis Children's Hospital, one of the top children's hospitals in the country, and they happen to live in the St. Louis area. And the question is, should only those children that are in St. Louis that have access to St. Louis Children's Hospital that have sickle cell be able to get that level of care? So if we go to the next slide. This is our new facility in Springfield, Missouri. I talked about this before. It's a joint venture with the rural health system. We are building a children's hospital there, and our goal is kids, just like I described to you in St. Louis, will not have to drive to St. Louis for 4 hours. They will not end up being transferred in a critical moment by helicopter. They will get that same care at this facility in Springfield, Missouri, in the middle of rural southwestern Missouri, and that will be because our experts in St. Louis will be able to provide that same level of care through virtual care, AI, and digital tools. And this is something we can do today to actually make this type of care available to all of our patients. So I'd argue this is why we come to work and do this type of work every day. All right, we'll go to the next slide. So if you want to follow some more of the work that we're doing, take a look on social media. We post regularly about a lot of these projects. You can see our recent publications. And with that, I'm very happy to take any questions.
Technically, at time, you want to do like 2 questions? Okay, so technically we've got a break coming up, but I know there are folks who have questions who are going to want to get them in. So we've probably got time for about 2 questions. So, yes. Sing out.
Can you hear me?
I cannot, but maybe Justin can repeat the question.
I'll repeat the question.
Get it. Mike's here. I'll get you a mic.
So we got a mic runner.
All right, great.
Here you go, bro.
Great. Thank you. Hi, so my name is Dean Billheimer. I'm a professor of biostatistics at University of Arizona. First of all, thank you so much for the presentation. I thought it was really great, very informative. And in fact, I would like a copy of your slides if you don't.
Sure. Yeah, happy to.
My question is, I noticed several times you describe really AI as the goal, in a sense, as augmenting intelligence. And I really appreciate that perspective. I can't help but notice the disconnect, though, that many of the examples that were presented are effectively how does AI compare with a human alone, right? And so it seems to me there's a real disconnect in terms of kind of the goal of some of the tools that have been built up to now. And then finally, I will say the few times the few references that I've seen outside of this talk where we did build AI as though it was an augmentation, the results are not very impressive. And the fact that humans plus computers performed worse than humans alone or computers alone. So I wonder if you have comments about that.
Yeah.
These phenomenon. And then secondly, how do we change the culture, I guess I'll call it, in terms of people who are building tools to think of them more as augmenting human experts, right? And because it seems to me that's where the huge, at least near-term benefits are.
Yeah, those are all amazing questions. So let me kind of take them a little bit out of order. So first, I think it's important to recognize that when we talk about sort of the performance of humans and computers together, we have to sort of contextualize, at least in my mind, in a system. There will be some tasks where the computer will be better than the human, some tasks where the human will be better than the computer, and then some where it requires the combination of the two. And it's really the aggregate performance within the system that matters as opposed to the individual tasks. So I think the unit of measure matters a lot. right? And to your point, there are certain tasks where we say, oh, we have to have a human in the loop because we're concerned about sort of the criticality of the decision or some ethical or regulatory barrier. Sometimes that actually does, as you noted, result in inferior performance than either alone. And so we actually have to study those phenomena and then make those decisions. And I think that is something that people struggle with because there is some anxiety around having fully autonomous agents in some tasks. And so that's where the evidence base also has to be very solid, and the ability to monitor and track over time. I think sort of stepping back when you mentioned sort of the performance envelope of these tools and how we understand them, one of the things I'm very committed to here, and I know a lot of my colleagues nationally have been pushing for, is we always have to evaluate these technologies against the existing sort of workflow, but then also if there is a superior outcome than the existing workflow, can we use that as a benchmark or comparator as well? And my best example of that is in ambient documentation. Everybody gets really worked up about, does an ambient scribe produce documentation that is equivalent to a human expert? Well, the reality is that documentation produced by human clinicians today is flawed and incomplete as well. So why is that the comparator? And then if that is not the ideal comparator, how do we find one that we believe is representative of what is necessary to deliver high quality, efficacious care? And so you really have to bring all of your research methodology sort of muscle to the table in order to do those studies. And it's not just turning it on and saying, did we save a few minutes or, did we move the needle on mortality? It's a much more complex set of questions to evaluate. And that's where, again, I would say informatics, data science, and biostatistics expertise becomes so central. And then the last thing I'll just say to your point is that to get the people building the tools to understand that, I think we have to get into a mode that is much more anchored on sort of a co-development model, not dissimilar from sort of novel diagnostics and therapeutics, where experts that understand clinical context and evaluation are working shoulder to shoulder with the technologists. And that requires breaking the sort of prevailing wisdom that this is an engineering problem. And I think we have a long way to go to get to that sort of shared vision.
I'm going to ask a proxy question.
Sure.
So we recently recruited Joseph Finkelstein, who we both worked with back at Columbia. I noticed in your presentation there was a huge amount of telehealth and remote monitoring with the AI. Is your position that to get the benefit of AI, the tele part is intrinsic, or is this specific to WashU's situation?
So I'll give an answer that's sort of my opinion, and I think it still remains to be proven. But I think certainly to get maximal benefit, we need to think about where, when, and how these tools are used. So one of my examples of that is, when we look at sepsis early warning systems, right? There's so many models that people have developed, and nobody has moved the needle in a meaningful way on mortality. We have seen in our own system that these models have a disproportionate benefit in some of our community and rural systems where incidence of sepsis is less frequent and the providers are not as familiar with either diagnosing or managing it. So there the question becomes, can you deliver that model there where it will have maximum impact, tailored to that population and environment? And then how do you support an intervention? They don't have critical care physicians in many of these facilities. And I don't think delivering the decision support without a transformative clinical solution will get you the results you want. And so that's why we've really tightly coupled virtual care in those settings with the AI-driven sort of interventions. And so I do think there's an increasing collision between those technologies when we get out of sort of urban centers and academic health centers and into sort of the places where the bulk of the population receive their care.
Great. So join me again in thanking Philip